Assalamu alaikum. Let's dive into a very high yield topic, that is contraception. Okay, contraceptive counseling should be patient centered and taken into consideration patient specific factor like medical history, the risk or benefit profile of various contraceptive methods, and the patient's future fertility desire. This is the very high thing you need to remember before giving contraception. Okay, what are the contraceptives? What are the contraception options? Intrauterine device, implant, female sterilization, male sterilization. These four: intrauterine device, implant, male and female sterilization. These has 99% efficacy. Injection, combined hormone contraceptives, condom, injection and combined hormone contraceptives near about 91 to 94%, and condom there is 82%, and withdrawal is 78%. Okay. Methods: combined hormonal contraceptives, pill, patch or ring. Adverse effect is breakthrough bleeding, breast tenderness and nausea. Breakthrough bleeding, breast tenderness, nausea. Depot medroxyprogesterone. In depot medroxyprogesterone, mm, it can cause initial irregular bleeding, amenorrhea, reversible. The depot medroxyprogesterone can cause reversible bone loss, delayed return to fertility, delayed return depot, delayed depot, delayed return of fertility, and it is reversible bone loss and without weight gain. Progestin subdermal implant can cause irregular bleeding. Progestin IUD can cause again irregular bleeding and amenorrhea. And copper IUDs can cause CD dysmenorrhea and heavy means. Copper CD dysmenorrhea and heavy means. Okay, now progesterone. Okay, progesterone. Adolescent with irregular menstrual bleeding due to anovulatory cycle may benefit from progesterone therapy. So, may benefit from progesterone therapy. Progesterone, which is normally secreted, from the corpus luteum during the ovulatory cycle and causes differentiation of the proliferative endometrium into the secretory endometrium, and withdrawal causes menstruation. Common side effects of injectable medroxyprogesterone contraceptives are vaginal bleeding or spotting and weight gain. Vaginal bleeding, spotting, or weight gain. Vaginal bleeding um, and weight gain. So injectable uh, depot medroxyprogesterone acetate. These can cause the side effects are the side effects are vaginal bleeding or spotting and weight gain. Vaginal bleeding or spotting and weight gain. Okay, the progesterone releasing subdermal implant is a long acting, subdermal long acting up to 3 years reversible contraceptive that reduce the menstrual bleeding in 50% patient and can cause amenorrhea in 20% patient. Useful for patient where estrogen is contraindicated. These pop progesterone things is used when estrogen is contraindicated. Okay, now OCP and IUD. Now OCP combined estrogen progesterone pills, combined estrogen progesterone pills. These OCP, before jumping into the adverse effect benefits, OCP, combined estrogen and progesterone pill, it prevent pregnancy through several mechanisms, like it can cause ovulation inhibition. It can cause ovulation inhibition. How? It can cause ovulation inhibition. It can cause cervical mucus thickening. It can cause cervical mucus thickening, and it can cause endometrial change. And finally, it decreases fallopian tube peristalsis. It decreases fallopian tube peristalsis. This is the mechanism by which OCP prevent pregnancy. So ovulation inhibition, this is the primary mechanism. In here, constantly elevated level of estrogen actually exert negative feedback on the hypothalamus. It exert the constantly elevated estrogen actually exert a negative impact on the hypothalamus, and thus inhibits LH and FSH. The suppression prevents mid-cycle LH surge. This suppression prevents mid-cycle LH surge required for ovulation. Okay, then the next thing, the next point, cervical mucus thickening due to progestin component. The increased cervical mucus viscosity prevent sperm passage. So ovulation inhibition via increased estrogen, cervical mucus thickening via progestin, and endometrial changes. The progestin component thins the endometrial lining, making it less suitable for implantation, and decrease fallopian tube peristalsis, again due to progestin component. The decreased peristalsis limit oocyte transport and helps fertilization. Okay, now adverse effect. Adverse effects: irregular, unscheduled bleeding, breast tenderness. There may be nausea, bloating, amenorrhea, hypertension, venous thromboembolism disease, liver disease. This one is very high. Serum Tg will be high. There is irregular, unscheduled bleeding. There is irregular, unscheduled bleeding. And the benefit is it can cause pregnancy prevention, menstrual cycle dysregulation. It can decrease dysmenorrhea and decrease hyperandrogenism, like acne, like hirsutism. And we know that PCO patient has this feature like acne, hirsutism due to hyperandrogenism. So we give oral contraceptive on PCO patient. And risk augmentation, um, decrease risk of ovarian and endometrial cancer if ever used, decrease risk of ovarian and endometrial cancer, and increase risk of cervical cancer. So it decrease risk of ovarian or endometrial cancer and increase the risk of cervical cancer. Should not be used in a woman more than 35 that use tobacco due to risk of myocardial infarction and stroke, due to risk of myocardial infarction and stroke. Okay, now hypertension due to increased angiotensinogen synthesis. Hypertension due to increased synthesis by estrogen and during fast fast metabolism, and discontinuing use can correct the hypertension in most patients. Very high, like discontinuation. If somebody has mild hypertension, if a patient is taking OCP, discontinuation of the taking OCP can correct the hypertension. So side effect and risk of oral contraceptive, like breakthrough bleeding, breast tenderness. It can increase TG, It can increase TG, it can cause amenorrhea, hypertension, venous thromboembolic disease, decrease the risk of ovarian and endometrial cancer, and decrease the risk of ovarian and endometrial, but increase the risk of C4C, increase the risk of cervical, increase the risk of survival, cervi cer and another OCP user, sometimes OCP user can happen these hepatic adenoma, very high yield. A hepatic adenoma should be remembered. Okay, now this is a superstar box for the upcoming exam, upcoming USMLE exam. Migrants with aura, more than 15 cigarettes, absolute contraindication to combine hormonal contraceptives. Migrants with aura increase more than 15 cigarettes per day plus age more than 35. Hypertension, hypertension more than 160 over 100 millimeter of mercury. Heart disease. Diabetes with end organ damage, history of thromboembolic disease, antiphospholipid antibody syndrome, breast cancer, mm, cirrhosis and liver cancer, major surgery with prolonged immobilization, and uses less than 3 weeks of postpartum. Weight gain is not a side effect of the OCP, not a side effect of OCP. Very high thing we should remember. Okay, progesterone and estrogen also affects the endometrial lining, which cause decreased breakthrough bleeding. This occurs because progesterone creates thin atrophic endometrium. Progesterone causes thin atrophic endometrium that can shed erratically, particularly with OCP that have low doses of estrogen, which normally acts to thicken and stabilize the endometrium. Okay. Mm, Therefore, breakthrough bleeding may be treated by prescribing an OCP a higher dose of estrogen. So, breakthrough bleeding can be treated with a higher dose of estrogen. What is preferred method of contraception for patient with breast cancer? Preferred method of contraception patient with breast cancer is copper iodide, very high yield. We should not give hormonal containing contraceptives. These are contraindicated in patients with breast cancer. Both estrogen and progesterone may have a proliferative effect on the breast tissue, and uh, can't all thus can't um, thus can effect on the breast cancer, what is the recommended contraceptive for a woman with a history of anemia and medication non-compliance, give levonorgestrel iod, typically causes amenorrhea, which is beneficial in patients with anemia versus copper iod, which can cause heavy menstrual bleeding. Copper iod can cause heavy menstrual bleeding. So levonorgestrel iod can be beneficial with anemia. Also, progesterone releasing iod does not affect also the progesterone releasing iod does not affect the thromboembolic risk, and less common side effects include mood changes, breast tenderness and headache. What are the contraindication of the IUD placement, copper iod or progesterone iod? The contraindication first is pregnancy, endometrial or cervical cancer. Unexplained vaginal bleeding, GTD, gestational trophoblastic disease, that hereditary familial carcinoma, severe uterine cavity distortion, and active pelvic infection, active pelvic infection, active PID. So the copper IUD or progesterone IUD is contraindicated in these cases. Progesterone IUD is contraindicated in current breast cancer and active liver disease, and copper IUD cannot copper Wilson, copper Wilson, because Wilson disease has a problem with copper metabolism, so Wilson copper cannot be given. Copper iod contraindicated. Progestin active liver disease and current breast cancer. Age and parity are not contraindication to IUD insertion in postpartum patient who are breastfeeding. Progestin only contraceptive methods. Progestin only Progestin only contraceptive in postpartum patient who are breastfeeding. Progestin only contraceptive methods, that is subdermal progestin releasing implant, progestin releasing IUD are preferred. Estrogen containing contraceptive are avoided due to increased risk of thromboembolism. So postpartum patient breastfeeding, progestin only contraceptive is preferred, like subdermal progestin releasing implant, progestin releasing IUD. These are preferred, but estrogen should be avoided due to increased risk of thromboembolism. Now, emergency contraceptives, uh, copper containing copper containing IUD, copper containing IUD, like efficacy is more than 99%, timing is 0 to 120 hours. Copper containing IUD, progestin releasing IUD, all the IUD, so three word 120 0 to 120 hours, and IUU Uliprestol 120 hours, 0 to 120 hours, and the Levo and OCP is 72 hours. Levo and the OCP is 72 hours. Copper containing IOD, copper, C for copper metabolism problem, in Wilson disease, it is contraindication, and active PID, it is contraindication. Copper containing IOD, Wilson disease, active PID, and uterine cavity distortion, these are the cause contraindicated. Progestin releasing IOD, contraindication is breast cancer, active pelvic infection, and uterine cavity distortion. And uliprostol, oral levogestrel, and oral contraceptives, these there are no contraindication. IUD contraindication if the patient has active cervicitis or PID. IUD, PID, so it is contraindicated. Okay, now time for questions. Okay, now look at this question. In this question, there is a 36-year-old woman, uh, not menstruating for 2 months. Okay, she received two depot medroxyprogesterone acetate injection for contraception. The last injection administered 4 months ago. Last means 4 months ago. Its efficacy 3 months. Its efficacy for 3 months. So it is given for it is last injection was administered 4 months ago. Over the past week, she begins experiencing bilateral breast soreness, weight gain, and increasing fatigue. Menarche was at age 14. Menarche occurred at age 14. Okay. Mm, Mens were regular prior to pregnancy. Mens were regular prior, but have been irregular since she was prior. Uh, since she taking medroxyprogesterone, the patient requests a different form of contraception due to these symptoms. So she has a breast tenderness, weight gain, and now fatigue. She wants a different uh, contraceptions. So she wants a different contraception. Before jumping into giving contraception, we know that it works for 3 months, but lady came after 4 months. So do and there are some signs like breast tenderness, weight gain, fatigue. These are the sometimes signs of the pregnancy. So should rule out the pregnancy test. So should rule out the pregnancy first. So perform a urine pregnancy test. So perform a urine pregnancy test. So menstrual irregularity are common in women who use menstrual irregularity are common in women who use medroxyprogesterone DMPA, which prevents pregnancy by inhibiting the release of gonadotropin releasing hormone from the hypothalamus and suppressing ovulation. In addition, DMPA can cause weight gain, it can cause fatigue and breast tenderness. This patient has experienced absent means for a month and bilateral tenderness, weight gain and increasing fatigue. This presentation could be attributed to the effect of DMPA. However, the same symptom is common in the early pregnancy, and we know that DMPA injection require are every 3 months. And here's her last administered time was 4 months ago. Therefore, before attributing the patient's symptoms to DMPA, patient must be excluded a urine pregnancy test. Okay, look at this question. These 8 months ago, subdermal progestin implant. Since then, unpredictable vaginal, unpredictable bleeding. Now she would like to have implant removed. She previously used OCP and would like to return. And she has primary hypertension. She has primary hypertension that was diagnosed last year. Okay. Uh, Combined OCP increases the risk of worsening hypertension. As she has hypertension, uh, these combined OCP can worsen her hypertension. Okay, worsening hypertension can happen. So, in contraindication to combined OCP, increased venous thromboembolic risk, increased venous thromboembolic due to tobacco use, prolonged immobilization, less than 3 weeks of postpartum, and thrombophilia, and increased cardiovascular risk, migraines with uncontrollable hypertension, ischemic heart disease, prior stroke, and medical condition negatively affected by estrogen is active breast cancer and active liver disease. Okay, look at this question now. 18-year-old or nulligravid woman, emergency contraception, a condom broke. Okay, yes, intercourse last night. Okay. Chronic medical condition, no chronic medical condition, physical examination is normal, pregnancy test is negative. Which of the common most effective contraceptive method? So mm, she she does not want to become pregnant for at least several years. So as she does not want to want to pregnant for several years, so we can give IUD. We can give IUDs like copper containing IUDs. So patients with recent unprotectable sexual intercourse, contraception failure, we need to give emergency contraceptive. Copper containing and 52 milligram progestin releasing IUD are the most effective. These two can be given. These two can be given. Okay. IUD insertion within 12 hours, within 120 hours, like 5 days after unprotected intercourse, prevent the pregnancy by impairing fertilization. IUD prevent fertilization and preventing implantation. In addition, IUD can be left in the place to provide continued contraception for up to 7 years for the 52 milligram progestin releasing IUD and up to 10 years for copper containing device. So 52 milligram progestin releasing IUD up and up to 7 years. So this progestin releasing IUD up to 7 years and copper and up to 10 years of copper containing IUD, but it may be removed sooner whenever the patient desires to pregnant. So which leads to an immediate return to fertility, which leads to immediate return to fertility. Okay, now look at this question. Look at this woman patient has no concern. She has uncomplicated vaginal delivery uncomplicated vaginal delivery 6 weeks ago. She would like to discuss a contraception option. So we should not give combined OCP. We should keep progesterone releasing intrauterine device or progesterone releasing contraceptives. Why? These levonorgestrel IUD, the progesterone release for postpartum patients. An early initiation of the reliable contraception prevents short interval pregnancy within 6 to 12 months and associated risk of preterm delivery. The choice of method depends on the future fertility plan, and postpartum timing, breastfeeding status, and medication history. Progesterone only method, progesterone only pin, medroxyprogesterone, and these are often used for breastfeeding patients, and there is almost no effect on the breast milk supply. These methods can be initiated either immediately after delivery, low thromboembolic risk with the progesterone only method, and or the postpartum visit more than 4 weeks of postpartum. The progesterone releasing IUD, which may be inserted immediately after placental delivery uh, or at 4 weeks of postpartum, is an ideal contraceptive option for the patient because it is primarily a locally acting contraceptive with a minimal systemic absorption. It has an added benefit of decreasing heavy menstrual bleeding by inducing amenorrhea. Okay, if we look at this question, a newly gravid woman comes to the office for routine checkup. She's concerned that she had gained 4.5 kg weight and believes that it is related to her OCP. And we have to reassure that her weight gain is unlikely to be caused by the combined OCP, because OCP does not cause weight gain. Very, very high concept. We should we need to remember to counsel the patient. For counseling purpose, we need to remember these things, that OCP does not cause weight gain. Okay, 32-year-old woman comes to the breast biopsy, feature confirmed high-grade malignant feature. Okay, she has breast biopsy. So as she has breast biopsy, so she has a breast mass, breast cancer. So we should not give the hormonal contraceptives. So we can give copper releasing IUDs. This is so cancer treatment with chemotherapy, highly teratogenic uh, treatment require effective contraception. So hormonal contraception, estrogen, progesterone method should not be given. And mm, in active breast cancer, which is absolute contraindication to hormonal contraceptive. Okay. Oh, okay. Look at this question. In here, there is a patient came here for discussion of the contraceptive option. 7 months ago, she explained a third spontaneous miscarriage and underwent recurrent miscarriage workup. So as she has underwent, so we cannot give hormonal contraception. Copper IUD is the must. Because if there is antiphospholipid antibody syndrome, we cannot give hormonal contraceptives. Absolute contraindication for combined hormonal contraceptives. Absolute contraindication for hormonal contraceptives. Okay, look at this question. This question, 14-year-old girl comes to you with by her parents to discuss for menstrual periods, 25 weeks of gestation, 4 months and neonatal. She spent 4 months in the NICU. She has cerebral palsy. And her mobility is limited due to spasticity. Her mobility is little limited due to spasticity. So, what type of contrast is best for treatment for this patient? Progesterone releasing subdermal implant. These insertion track It is inserting at the mid 8 to 10 centimeter from the medial epicondyle. This is, so pubertal transition can be complicated by physical or intellectual disability. Adolescents with disabilities may become dependent on the caregiver for menstrual hygiene and limiting their independence and creating embarrassment, especially when uh, they, there is heavy menstrual bleeding, or severe dysmenorrhea. Menstrual management with hormonal contraception can be used to minimize the menstrual bleeding volume. So a progestin releasing subdermal implant, a, a long acting, it can work up to 3 years, and a reversible contraceptive that reduce menstrual bleeding in 50% of patient and causing amenorrhea in 20% of the patient. That's why it is given. So this patient with um, cerebral palsy, we should give some sort of contraceptive which acts longer and thus decreases heavy bleeding. In here, look at this patient. She is currently diagnosed with hypertension and prescribed as AC inhibitor. So we should not give the hormonal OCP. We should give copper IUD. Copper IUD, there is no hormone is present, so though no effect on hypertension, high risk efficacy, not no effect on future fertility, no effect on future fertility. If we look at these questions and look at these other questions, like look at this question, postpartum visit contraception. 2 weeks ago she had a vaginal delivery, 36 weeks of gestation. So she is breastfeeding exclusively with no issue. So for pregnant lady, for she takes daily iron supplementation. She takes iron deficiency anemia due to heavy menstrual bleeding. So what is the best contraceptive option for this patient? Subdermal progestin implant. In here, in here, in here, the choice of postpartum contraception based on the time of the delivery, breastfeeding status, okay, and um non-hormonal contraceptives and progestin only contraceptives are preferred less than 1 month of postpartum and breastfeeding. However, in this patient, heavy menstrual bleeding. Okay, look at this patient. In this patient with heavy menstrual bleeding complicated by anemia, the copper IUD may increase menstrual bleeding. The copper IUD may increase the menstrual bleeding and can worsen pre-existing anemia. That's why progestin only contraceptive method can help to decrease the menstrual bleeding while also providing contraception. In this patient who desires reliable contraception to avoid subdermal progestin releasing, this subdermal progestin, we are not using copper IOD because this patient has a heavy menstrual bleeding, so we should not give copper IUD. Mm, Okay, look at this question. What are the most appropriate contraception option for these patient? She has factor 5 Leiden carrier, so we should not give hormonal contraceptives. Progestin releasing IUD should be given. This patient factor 5 Leiden carrier, progestin releasing IUD because it takes consideration. So progestin releasing IUD because it takes constant increased risk of thromboembolism. She is a heterozygous and family member, so we should not give uh, combined OCP estrogen progesterone because it increases the risk of thromboembolism as she is a factor 5 Leiden carrier. And we should not give copper IOD because heavy menstrual bleeding also associated with anemia, and she is desired for future fertility, which is possible with IUD and removal of at any time or desired pregnancy. In addition, the progestin releasing, that's why progestin releasing IUD is preferred in here. Progestin releasing IUD is preferred in here. Okay, look at this question in here. she wants comes to the office for emergency contraceptive. The patient stopped breastfeeding 1 month ago and has restarted her OCP because her husband scheduled for a vasectomy in a few weeks unprotected last night. So, on which she needs an emergency contraceptive like single dose of olipristal acetate is a very good drug for 0 to 120 hours. Okay, the final question. Okay, look at this final question. Look at this final question. In here, we should keep depot medroxyprogesterone because con contraception counseling takes a consideration factor and it provides contraception. And in this patient, the most appropriate concentration is DMPA because preference and ease of use, uterine cavity distortion. She has uterine cavity distortions. So copper contraindication of the devices and desire for future fertility. That's why DMPA, diphenhydroxyprogesterone acetate, is an effective injectable contraceptive. They do not require daily administration, and it is a safe choice for this woman. Okay, for her future fertility. Okay, that's a very long discussion. Hope you enjoy.